Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy professional life. I'm Sangeeta Krishnan, medical editor at MIMS Learning, and I'm delighted to have my colleague here with me today.
Hi, I'm Pat Anderson.
So today I wanted to talk about vision problems and eye disease.
Yeah, both great topics. I'm happy to say we have some brand new CPD on MIMS Learning about them. For example, we've got a new red flags module about vision loss and another one on thyroid eye disease. We know that GPs feel they don't get a lot of training on eye conditions, so we're trying to do what we can to fill the gap. I've had a quick look at some stats around eye problems, and apparently more than 2 million people in the UK are living with sight loss, and this is expected to rise to 2.7 million people by 2030.
That's a lot of people.
That is really a lot of people, and I bet it doesn't include people like me who've worn glasses all their life for relatively minor problems. According to the WHO, the leading causes of vision impairment globally are age-related macular degeneration, cataracts, diabetic retinopathy, glaucoma, and uncorrected refractive errors. People of Black, African and Caribbean heritage are more at risk of glaucoma and diabetes-related eye disease, while people of South Asian heritage have an increased risk of diabetes-related eye disease. And this figure is what really amazed me. An estimated 50% of sight loss is avoidable.
Wow. Knowing that half of all sight loss is avoidable, that is a shocking statistic.
So there is a really big role for GPs here, as well as dealing with the specific eye symptoms and conditions we're going to talk about in this episode. The prevention agenda is huge. So, for example, reducing obesity, stopping people from smoking and providing good diabetes care are absolutely crucial to prevent or slow the progression of vision problems.
Yep. And loss of vision is not the only symptom I'd like to discuss today. We'll also touch upon other eye symptoms and conditions, including blurred and double vision and thyroid eye disease. So we have plenty of ground to cover in a short amount of time. Let's get to it.
Absolutely. So let's start with the red flag symptoms for loss of vision, which I already mentioned, and this has been written by Dr. Pipin Singh. He says it's important to establish what the patient means by loss of vision and to find out more about what they hope to gain from the consultation, as they may be feeling very anxious.
Absolutely. Feeling anxious in these situations would be totally normal. From a GP's perspective, it's all about meeting the patient where they are, unpacking their thoughts and feelings about the situation, and finding out what's worrying them the most. Some of the red flags associated with loss of vision include when the vision loss has a sudden onset, the presence of associated weakness in the face or one of the arms or legs, loss of power in the upper or lower limb, persistent paresthesiae, red eye pain, and double or blurred vision. Once a thorough history is taken, the patient should be examined.
Yes, to add to that, Dr. Singh says in his module that smoking and alcohol history may also be relevant in this scenario. The role of smoking in exacerbating a range of eye conditions, including age-related macular degeneration, thyroid eye disease, and diabetic retinopathy, is fairly well known.
When it comes to examining someone with loss of vision, Dr. Singh says that it's important to consider whether the patient is in work or whether they attend school, college, or university, as this will likely affect management. Vision loss can be objectively assessed using a 3 or 6 meter Snellen chart. The examination could include the external part of the eye, checking the range of eye movements, and the pupil reactivity. A more detailed neurological examination may also be needed, depending on the history. And depending on findings, a referral may be necessary.
Yes, an urgent ophthalmological assessment may be relevant, depending on findings, or urgent neurological evaluation may be needed if there's a primary neurological problem like multiple sclerosis that is suspected. Urgent stroke assessment may be necessary if it's felt to be a vascular etiology, and if giant cell arteritis is suspected, same-day rheumatological assessment may be needed. So, Sangeeta, what are some of the possible causes of vision loss?
So, vision loss could be due to ophthalmological causes like scleritis, uveitis, glaucoma, and intracranial hypertension. It could be due to neurological causes like multiple sclerosis and migraine, and vascular causes such as temporary arteritis and amaurosis fugax.
So hang on, what's Amaurosis fugax?
I had to look that one up. Amaurosis fugax is when there is temporary loss of sight in one or both eyes. It usually happens when the blood flow to the retina is disrupted. Amaurosis is a Greek word that means dark, and fugax is a Latin word which means fleeting.
I get the feeling they're mixing up their classical languages there. But good to know about that condition. And apparently it's also worth remembering that certain drugs such as hydroxychloroquine, systemic steroids, amiodarone and isotretinoin may also be responsible for visual loss. And am I also right in thinking that there are autoimmune conditions that can affect the eye?
Yes, there are. So, aside from multiple sclerosis, which can lead to vision loss through inflammation of the optic nerve, there are several. Sjogren's syndrome, which chronically affects tear glands, can lead to severe dry eyes, while systemic lupus erythematosus could lead to a blockage causing a stroke in the eye. Thyroid eye disease is another autoimmune condition of orbital tissues that tend to occur in those with Graves' disease.
Great, so this brings us on to our new module on thyroid eye disease, which is written by ophthalmologist Miss Rebecca Ford. So what's a common manifestation of thyroid eye disease?
The bulging eyes that we see in goiter pops to mind straight away.
So yes, you're right. Although the presentations of thyroid eye disease can vary widely, double vision can develop as a result of extraocular muscle involvement, and visual loss can occur because of optic nerve compromise or corneal exposure. But as you mentioned, proptosis, where the eyeball protrudes from the orbit, is a common sign of thyroid eye disease. Other common signs include soft tissue swelling and eyelid retraction, which occurs in 90% of patients, and may be because of increased sympathetic drive or direct involvement of the levator muscle. Although only around 20% of people with Graves' disease will have eye changes in their first presentation, up to 90% of people who develop thyroid eye disease will either currently have Graves' disease or have a history of the condition.
So, does that mean even those who don't currently have active thyroid disease are still likely to have the thyroid eye disease?
That's possible because thyroid eye disease is known to present even decades after the original period of hyperthyroidism. A smaller proportion of individuals present while they're hypothyroid, and up to 5% present when euthyroid and with no prior history of thyroid dysfunction. So in the module, Miss Ford says that clinicians should consider thyroid eye disease in all of those with Graves' disease, presenting with red and swollen eyes, but also be careful not to rule it out in people who are not known to have an existing thyroid condition. Overall, the incidence is about 25 people per 100,000, and women are 9 times more likely to develop thyroid eye disease than men. How would you expect it to be diagnosed?
I would guess, aside from the ocular symptoms, thyroid hormone levels will need to be checked.
Yes, especially if someone's thyroid function is not known, they'll need to be tested. So TSH receptor antibodies, or TRAbs, which are directed against TSH receptors, are the main identifiable autoantibodies in thyroid eye disease and in Graves' disease. So TRAb levels can be checked, and high levels will be suggestive of Graves' disease. Imaging can demonstrate the state of the orbital tissues and help specialists to plan treatment. Thyroid eye disease also follows a disease pattern which consists of an active phase of inflammation and disease progression, followed by an inactive phase with no progression, but where sequelae may remain.
Just going back to what you said earlier, you mentioned the double vision or diplopia is one of the common symptoms of thyroid eye disease. I just wanted to mention that we have learning around the red flags associated with diplopia.
Yes, in another module on diplopia red flags, written by our red flags supremo Dr. Pipin Singh, some of the red flag symptoms associated with diplopia include persistent headaches, changes in pupillary size, drooping of the eyelids, ocular fatigue on excessive use, and loss of vision. So if diplopia presents with loss of vision or protruding eyeballs, as mentioned above, these would be considered red flag symptoms.
That's interesting. So, an important question to ask the patient is exactly what they mean by double vision, given it's important to distinguish this from blurred vision.
Yes, and the module also says patients will tend to look up their symptoms on the internet.
I've most certainly never looked up my own symptoms on Dr. Google.
Yes, I'm sure you haven't. Yeah, we all tend to do this, and so it is important for the GP to understand the patient's ideas, concerns, and expectations. Dr. Singh says the examination should focus on the history, and clinicians should look out for any obvious changes such as discrepancy in the size of the eyelids, range of eye movements, and reactivity to light and accommodation. He also notes an examination of the facial bones should be done to exclude orbital floor fracture. And when would you need to refer someone with double vision?
An urgent referral may be necessary when the symptoms are acute, and the module says to consult local advice and pathways if unsure whether a neurological or an ophthalmological referral is warranted. A referral to drug and alcohol services may be appropriate in situations where excess alcohol use is suspected.
Now, you mentioned it's important to distinguish between blurred and double vision. So, what actually is the difference between those two presentations?
So, although diplopia is not a very common presentation in primary care, blurred vision is. According to the Cleveland Clinic, monocular diplopia happens when you have double vision even when you close or cover one of your eyes. It may look like there are shadows in your vision. Monocular diplopia is the most common and usually the least serious type. Binocular diplopia is having double vision when both of your eyes are open. It goes away if you cover or close one eye. Binocular diplopia is usually more serious. Blurred vision is when the eye cannot focus and vision isn't sharp and crisp.
Okay. And I understand that diplopia has quite a wide range of differentials.
Yes, it does. So the causes of diplopia can be ophthalmological in nature, like strabismus in children, refractory errors, or temporal arteritis. Neurological causes include myasthenia gravis, nerve palsies affecting the third, fourth, and sixth cranial nerves, and Horner's syndrome. Other causes can include certain drugs, alcohol intoxication, and thyrotoxicosis.
And what about the causes of blurred vision? Presumably there are lots of causes of that.
Yeah, there are. So, ophthalmological causes can include a corneal ulcer, vitreous hemorrhage, cataract, and glaucoma. Neurological causes can include multiple sclerosis, papilloedema, and migraine. Vascular causes include occlusion of the central retinal artery or vein, stroke, and temporal arteritis. Other causes include diabetes and alcohol intoxication.
That's really interesting to know. So, we've talked about blurred and double vision, and we've discussed thyroid eye disease. I'd like to cover off one final symptom, which is eye pain. Dr. Singh has also included this in his red flag series. So can you remind me of some of these red flags, Sangeeta?
Sure. So, the red flags for pain in the eye include sudden onset, photophobia, any recent trauma, vomiting, or a history of malignancy, and flashes or floaters. In the module, Dr. Singh says to palpate the adjacent sinuses to look for tenderness, and it also may be necessary to palpate the temporal artery to look for tenderness with or without loss of pulsation. As well as examining visual acuity with the Snellen chart, the third, fourth, and sixth cranial nerves should also be checked. Do we know the possible causes of eye pain?
Well, we know some of them. The ophthalmological causes could range from styes, blepharitis, and skin malignancy to iritis, scleritis, and corneal abrasion. Migraines, ophthalmic shingles, temporal arteritis, and acute sinusitis are also potential causes of eye pain. The module has a more extensive list of causes and red flag symptoms, but what I really like about this one is that there is quiz-based learning with images of some of the conditions that could cause eye pain.
Yes, and I wanted to add that history is important for these symptoms and will guide examination and treatment. What could be some questions a GP may consider asking, Pat?
So they could ask whether the symptom is unilateral or bilateral, whether there have been any flashes or floaters, when the symptoms started, and whether there have been any changes in the eye or pupil. GPs may want to ask about whether the patient drives or whether they're attending university or school. And as mentioned, many patients may have researched the symptoms themselves and they'll have their own ideas about it, so it would be probably worth asking them what they believe and what they want.
So, what have we learned today? Here's a quick recap of some of the take-home points from our discussion. First is that GPs have a vital role to play in preventing vision impairment or slowing its progression. All that you do to reduce obesity and manage diabetes effectively will help reduce the numbers of people with eye problems in the future. The second one's that don't forget that sudden onset loss of vision is a red flag, along with the presence of associated weakness in the face or one of the arms or legs, and loss of power in the upper or lower limb. Urgent referral may be required in these cases. And finally, up to 90% of people who develop thyroid eye disease will either currently have Graves' disease or have a history of the condition. The period of hyperthyroidism may predate eye problems by years or even decades.
Thanks, Sangeeta. And just one more thing before we go. Dr. Singh has also written a new red flags module on red eye, kind of filling a little gap in the red flags coverage. So do look out for that in 2025.
Thanks, Pat. Don't forget that you can claim CPDRs for listening to these podcasts, and there are plenty more on the MIMS Learning website. Thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Look out for our new episode next Friday, where Dawn Liz Powell will interview Professor Alex Miras about how GPs can support people living with obesity. We'll see you again soon.